Assalamualaikum and hi. Today our group will be presenting our group clinical case conference for the course FFFJ 1323 Fundamental of Nursing 2, where the case study that we took and focus is the patient from Ward Medical 7C. So before we begin, I will introduce our group members. Kapsha Elina binti Muhammad Hasri, Nur Syafiqah Rifka binti Abdullah, and Maisara binti Muhammad Rizwan. Moving on to the patient's profile, the RN number for this patient is N988864. Mr. H is a 21 years old male and he is working as a soldier. So the medical diagnosis for this patient is acute exacerbation of bronchial asthma, AEBA, secondary to community acquired pneumonia. So for his underlying condition, he has a history of childhood bronchial asthma which worsened since early April and requiring weekly nebulizer at RSAT where he works. And he also have allergies, rhinitis, but declined eczema. Now looking at his social history, he is an ex-smoker and ex-vapor, and he has an elder brother who has bronchial asthma as well. And then he previously was smoking since 12 years old, where he consumed 4.5 packs per day. But however, he stopped after 2 months ago. He also has recently relocated to a bachelor house, and he has no known food or drug allergies. For the chief complaint, the patients presented with shortness of breath, dyspnea, wheezing during expiration phase, having a productive cough and sore throat, especially during exercise, cold weather and at night. And he also mentioned of needing an inhaler almost every day, and he experienced prolonged expiration. And now let us look at the assessment data, which we have divided into subjective and objective data from the assessment that we have collected from the patient. So for subjective data, the patient complained of a notice of wheezing sound during expiration phase, difficulty to breathe normally, especially at night, having a productive cough and sore throat, and he also required a nebulizer almost daily, specifically 4 times per week for 1 month. For objective data, we look at his vital signs which show his blood pressure of 130 and 19 mmHg, and the oxygen saturation at 95%, heart rate of 86 bpm, respiration rate of 30 breaths per minute, and his temperature is 36.7. Additionally, he also had asthma control test, ACT, which show a score of 5. And upon assessment as well, he had a prolonged expiratory phase where equal A entry but no rhonchi for chest auscultation. And then for diagnostic finding, from the blood test, his eosinophil are at 1.82, which is higher than normal range, and his chest X-ray result in hyperinflated lungs and no obvious consolidation.
The Q clustering for this patient is the first one. Mr. H has wheezing during expiration, prolonged expiratory phase, and respiratory rate 30 breaths per minute. This indicates airflow limitation due to bronchospasm and airway inflammation. Mr. H also have difficulty breathing, especially at night. His oxygen saturation is 95%, which is quite low. This suggests poorly controlled asthma with impaired oxygenation. Mr. H also has productive cough, sore throat, and eosinophils of 1.82, which is quite high. This indicates that Mr. H has airway inflammation with excessive mucus production. This is likely associated with allergy and airway response. Mr. H also requires nebulizer 4 times per week for 1 month, and his asthma control test is score 5, which is quite low because the normal one is 20 to 25. This suggests poor asthma control and inadequate long-term disease management. Mr. H also have hyperinflated lungs on chest X-ray. This indicates that there is air trapping caused by chronic airflow obstruction. For the next one, for the nursing diagnosis, the first one that is prioritized is impaired gas exchange related to ventilation perfusion imbalance as evidenced by dyspnea. The second prioritized is ineffective breathing pattern related to airway inflammation as evidenced by prolonged expiratory phase, dyspnea, wheezing, and productive cough. For the third that is prioritized is ineffective health management related to deficient knowledge regarding correct metered dose inhaler, dose inhaler MDI technique as evidenced by inability to demonstrate the correct technique of MDI and ACT score of 5. For the nursing analysis, it follows PS statement format. For the first one, the problem is in bright gas exchange. The etiology is related to ventilation perfusion imbalance, and the sign and symptom is evidenced by dyspnea. For the second nursing diagnosis, the problem is ineffective breathing pattern, etiology related to airway inflammation, and the sign and symptom is evidenced by prolonged expiratory phase, dyspnea, wheezing, and productive cough. And for the last one, the tetanus diagnosis, the problem is ineffective health management. The etiology is related to deficient knowledge regarding correct metered dose inhaler MDI technique, and the sign and symptoms is as evidenced by inability to demonstrate the correct technique of MDI and NCT score of 5.
Now we move into care plan. So for the first nursing diagnosis, which is impaired gas exchange related to ventilation perfusion imbalance as evidenced by dyspnea. So our desired outcome, which is within 34 hours, the patient will maintain oxygen saturation more than 95%, report reduced shortness of breath, and demonstrate improved oxygenation. So for the nursing intervention, the first one is monitor oxygen saturation and respiratory status regularly, which to detect deterioration or improvement in oxygenation. The second one is assess for signs of hypoxia such as cyanosis, restlessness, or confusion. This is to enable early recognition of inadequate oxygenation. The next one is position the patient in high volus position. This is to maximize lung expansion and improve ventilation. The next one is monitor PEFR before and after nebulization, which evaluates improvement in airflow. And the last one is administer oxygen therapy as prescribed. This is to increase oxygen delivery and improve gas exchange. The evaluation is the patient experience reduced shortness of breath with improved oxygen saturation and gas exchange. For the second nursing diagnosis, which is ineffective breathing pattern related to airway inflammation as evidenced by prolonged expiratory phase, dyspnea, wheezing, and productive cough. So the desired outcome is within 24 hours, the patient will demonstrate an improved breathing pattern with reduced dyspnea and wheezing. So for the nursing intervention, the first one is assess respiratory rate, rhythm, depth, and breath sounds, which to monitor respiratory status and detect deterioration. And the second one is position the patient in high volus position to promote lung expansion and ease breathing. The next one is monitor peak expiratory flow rate (PEFR) before and after nebulization, which to evaluate airway obstruction and treatment effectiveness. The next one is administer nebulization as prescribed, which to relieve bronchospasm and improve airflow. And the last one is encourage adequate rest and avoidance of asthma triggers. This is to reduce oxygen demand and prevent worsening symptoms. So the evaluation is the patient demonstrated an improved breathing pattern with reduced dyspnea and wheezing. So the last care plan for our last nursing diagnosis, which is ineffective health management related to deficient knowledge regarding correct metered dose inhaler technique, as evidenced by inability to demonstrate the correct technique of MDI and NCT score of 5. So the desired outcome is within 34 hours, the patient will demonstrate the correct MDI technique and verbalize the importance of adhering to the prescribed asthma medications. So for the nursing intervention, the first one is assess the patient's current understanding, technique of MDI use, and the importance of medication given. This is to identify specific knowledge gaps and baseline coordination errors. The next one is demonstrate the correct MDI technique, which to improve medication delivery and asthma control. The next one is ask the patient to perform a written demonstration. This is to ensure the patient has understood the correct technique. And the next one is educate the patient on the importance of medication adherence and avoiding asthma triggers to prevent future asthma exacerbation. And the last one is position patient into high follower comfortably in bed to ensure the patient in correct position and increase effectiveness of medication for MDI use. So the evaluation is the patient demonstrated improved understanding of the correct MDI technique and verbalized the importance of medication adherence. Now we'll be move on into implementation and evaluation. So for the first nursing diagnosis, which is impact gas exchange related to ventilation perfusion imbalance as evidenced by dyspnea. So the first implementation that we did was monitor oxygen saturation and respiratory status. This is to assess the patient oxygenation level status. The second one is assessed for signs of respiratory distress. This is to detect early deterioration in gas exchange. The next one is administer nebulizer convivent as prescribed. This is to improve ventilation and gas exchange by relieving bronchospasm. And the last one is monitored PEFR before and after nebulization to evaluate improvement in airflow following treatment. So the evaluation is called MET. The patient maintained oxygen saturation at 98 to 100% under room air with no shortness of breath at rest. Next, for the second nursing diagnosis, which is ineffective breathing pattern related to airway inflammation as evidenced by prolonged respiratory phase, dyspnea, wheezing, and productive cough. So the first implementation that we did was assessed respiratory rate, breathing pattern, and breath sounds to monitor the patient's respiratory condition. And the next one is positioned the patient in high follows position. This is to promote lung expansion and ease breathing. The next one is administered nebulizer convivent as prescribed, which to relieve bronchospasm and improve airflow. The next one is monitored PAFR before and after nebulization to assess the patient's response to bronchodilator therapy. And the next one is advise the patient to avoid known allergens and triggers to reduce the risk of asthma exacerbation. So the evaluation is goal partially met. The patient's breathing pattern improved with reduced wheezing and dyspnea, but prolonged respiratory phase was still present. Last but not least, for our last nursing diagnosis, which is ineffective health management related to deficient knowledge regarding correct methadose inhaler technique as evidenced by inability to demonstrate the correct technique of MDI and ACT score of 5. So the implementation that we did for this nursing diagnosis is the first one is assess the patient's current understanding, technique of MDI use, and the importance of medication given. This is to identify specific knowledge gaps and baseline coordination error. So the next one is position patient into high folio comfortably in bed. This is to ensure the patient in correct position and increase effectiveness of medication for MDI use. And the next one is demonstrated the correct step of MDI technique. This is to enhance learning and ensures correct deposition of medication into the lower areas instead of the mouth. And the last one is encourage patient for proper timing of doses and reminding to rinse the mouth after using inhaler. This is to promote therapeutic compliance, prevents acute exacerbation, and reduce local side effect like oral thrush and sore throat. The evaluation is goal partially met. The patient showed better understanding of the correct inhaler technique but still require enforcement.
So, through this case study, we are able to learn on how to assess a patient with acute exacerbation of bronchial asthma, and then identify and also prioritize nursing diagnosis, and then develop an appropriate nursing intervention to apply for the patient's care. We also have a better understanding on the importance of patient's education, especially on the correct use of metered dose inhaler, which is MDI, and how we can help the patient to improve his asthma control. The biggest challenge that we went through was how we need to prioritize the nursing diagnosis and then select the most appropriate intervention based on patient's condition throughout our care. We believe we could improve more in our nursing care as well as improve our presentation by explaining our clinical reasoning more clearly and followed by strengthening our nursing intervention and the quality of our care for the better outcome. Thank you.